So you're going to have some good talks on torsional problems this morning, and you've had them throughout the course. It's important, and I'm going to try and focus on children because that's what I do. Give you an idea of analysis, the effects of torsion on the knee, and how that impacts your decision-making process. But remember, we don't really understand torsion very well. There's a lot of literature on coronal malalignment and the effect on the patellofemoral joint, but the role of torsion is a little bit more obscure. And that's partly because it's never an isolated problem. It's often associated with other risk factors, and working out the contribution of all of these is difficult. Also, the literature on torsion and its effect on the patellofemoral joint, most of the data comes from Germany and China, and in particular one province in China. So what we're looking at is a geographical representation when we look at evidence. But let's start with a clinical example. There is no right or wrong answer here, whatever you say. This is a 9-year-old who presents with recurrent patellofemoral dislocation. Both her knees are bad, but the left side is worse. Her left side, she has habitual dislocation in extension. So she straightens her knee and the patella slips off laterally. You can see from the CT scan, her trochlea is dysplastic, but her patella height is normal. And there's not really any other abnormality such as the TTTG. This is her CT rotational profile. I do them, and I'll justify why I do it. But those are her measurements. That's her arthroscopy with her knee in 30 degrees of flexion. You can see that most of the lateral facet sits on the opposite side of the edge of the lateral femoral condyle. Sorry, that's the lateral facet of the patella there. That's the edge of the femoral condyle, 30 degrees flexion. This bit should be over here, okay? Does that make sense? So what you're going to do, who would derotate the tibias as part of their treatment plan or would consider it? Hands up. Don't be shy. No one is going to be wrong whatever you say. Who would derotate the femur? Anybody? Who would derotate both as well as treating the knee? Okay, so very various, and lots of you don't put your hands up, which tells us that we're not sure what we should be doing, even though the numbers there are quite high. So this is what I did on the left. So you can see here, the right side, she can't fully extend because the kneecap will come out. But she's had a tibial derotation and reconstruction of her knee. But why have I done that? What's my evidence? What have I based the decision-making on? So when we talk about the patellofemoral joint, if you have femoral torsion, it increases the valgus angle of your quads. So basically that twist in the femur, particularly when you're walking, it will drag over the quads mechanism and affect the patellofemoral joint. And the same is true of external tibial torsion. That will also drag the quads over. So basically, both of those deformities, external tibial torsion, internal femoral torsion, will cause a lateral vector on the patella. And when you have that deformity in both bones, it's miserable malalignment, something that's quite difficult to treat without input. And so basically, if you deal with this torsional problem, the theory is that you will reduce patellofemoral pain in cases where it's present, and you may also decrease the level of instability patients have. We've talked a little bit about how we measure torsion. It's to do with, obviously, all your static examinations, and I agree completely with what's been said already, but also look at the feet. Foot position will affect the valgus moments at the knee. Ligamentous laxity as well, obviously. But sometimes it's more complicated than a static examination, just a physical examination of the lower limb. And this is an example of someone doing heel-toe walking. You can see on the right that there is an external foot progression angle. And when she comes back the other way, you can see the patellae point forward. But the reason I've done gait analysis here is because she's got a functional neurological disorder and is complaining of patella dislocating medially, which it actually isn't. So sometimes it's quite careful to look a little bit more carefully. Now, we've talked a little bit about imaging. CT does involve radiation dose, but if you have a department where they do it regularly, they can do a few slices of the hip, knee, and ankle to get your measurements. But MRI can supersede that. Also, we can use EOS as well. But remember, when you're doing a CT scan, ask how your radiologist is measuring it. Don't worry too much about all of these lines. Look at the box plots, because these are all different techniques of measuring the same thing, and notice that they're all slightly different. EOS has the advantage of low levels of radiation, assessing other deformities, and we might see that as well as MRI take over how we measure torsion. But also remember that we've not even talked about the acetabular version here, which also has an impact on your alignment. And the same is true when we're measuring tibial torsion as well as femoral torsion. The differences that you see with how you draw your lines, and that's assuming your lines have been done correctly, are quite dramatic. So bear that in mind. But what you guys want to know is what figure should you correct things? And hate to be a spoiler, but I'm not going to give you a figure. And that's simply because of what I've said already. We don't know what normal is. Normal varies from population to population. It varies with the age of the patient. And there is no answer with strong evidence. But this nice systematic review that comes from the Americas tells us that if you look at the literature, what's been published, people aren't derotating tibias with less than 30 degrees external tibial torsion and less than 25 degrees femoral anteversion. But whether that's right or wrong, it's difficult to know. But is it worth derotating for instability? This recently published systematic review, you'll be surprised how little data there is, but there are 2 comparative studies. They're comparative, okay? So it's level 3 or worse evidence. But what they show us is if you pick bits out, it does seem to make a difference for patellofemoral instability in comparison to MPFL reconstruction on its own. But very subtle features. So the top right is box charts that show you Kujala scores. So it does favor derotation. The bottom is resolution of the J sign, which tells you that derotation may affect the tracking of the patella in a positive way. But the differences are small. And when you delve a little bit more detail into derotation, look at this article here. These graphs come from Andreas Imhoff in Munich, 150 patients, adult patients, with derotation and patellofemoral instability. What he's shown is that basically the box charts, if you've got torsional problem, you're more likely to have high-grade trochlear dysplasia on the left, and you're more likely to have an abnormal TTTG. So there seems to be a relationship between torsion and other abnormalities within the knee. And is that because we're measuring it wrong? We've heard already that CT is not very good at predicting outcomes, but that might be because what we're measuring is not right. This is another recent study that's been published from the group I mentioned in China, in Hubei province. And what they've found is that if you measure off the posterior condylar axis, which is what we do with CT, the reason you might find it's not really associated or it's associated with trochlear dysplasia is because the condyles aren't in the right place. So maybe we're measuring it wrong. And that's exactly what you've heard already, that femoral anteversion angle, where we draw a line along the axis of the femoral neck and the posterior condylar axis, doesn't correlate well with the patellofemoral instability. But that's probably just because things are a bit more complicated. And sorry, but it gets even more difficult. Okay, because if you look at where the torsion is in the bone, you find that there is an association with it being closer to the knee and the femur. Okay, so we all see kids with persistent femoral anteversion. How many do you see with pain in the 6 to 9 age group? Very few. Is that simply because the pull of the muscles is affected where the torsion is in the bone? It seems to be less important with the tibia, and tibial torsion does correlate better with symptoms. And all of this, in terms of putting it together, the next stage we're going to be looking at is the rotation of the quads. Simply because quads might be the result of torsion and in terms of the pull. So this is a whole field that's developing. So basically, take-home messages are, torsion is difficult, and we don't have a lot of evidence to guide us in management. But you should consider derotation where you have kids in particular with patellofemoral instability, because we know the failure rates for isolated MPFL reconstruction, although they're good for 2 years, 5-year follow-up, about quarter failure if you look at the big studies. Know how your radiologist measures, always check where they draw their lines, and don't base your decision just on a measurement, because there isn't a measurement that works. But the problem that we're having with torsion is we don't fully understand its relationship with patellofemoral instability yet. That will come with time. Thank you.